Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. C.B. Keshava Murthy. Sir is MBBS, MD General Medicine, DM Cardiology, DNB Cardiology, consultant at Manipal Hospital, Mysore. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is management of tricuspid valve disease. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you so much. I hope the audio and video are both clear.
Yes, sir, you are absolutely clear.
Yeah. A warm welcome to all the participants. I will be speaking today. I'll be sharing a few thoughts on tricuspid valve and how it is, a few points on its anatomy, what are the diseases affecting the tricuspid valve, and of course, the interesting developments that have taken place in the recent years in the treatment of tricuspid valve disease. Thank you for participating in this session, and I hope it will be useful to you in your day-to-day practice in treatment of patients and making their lives better. So we all know that tricuspid valve, I'll be talking on these topics: introduction, anatomy, disorders, relationship with diseases of other valves, how to diagnose these conditions, what are the investigations that are appropriate, and treatment and recent advances. So this is a brief anatomy of the tricuspid valve. We all know that tricuspid valve is the right-sided valve situated between the right atrium and the right ventricle. So you can see that it is situated on the right side of the heart between the right atrium and the right ventricle and regulates flow between the right heart chambers. So it has a complex subvalvular structure and three leaflets. And also one of the peculiarities of the tricuspid valve I would like to highlight today is that being present in the right heart, it is exposed to low pressures, both at opening and closure. The mean right atrial pressure is 0 to 5. We know that right atrium is a low pressure chamber because it has to receive blood from the venous side of the heart. The right ventricle has a peak pressure of 8 to 12 millimeter Hg in the normal circumstances, but it can take pressures up to 50 or 60 when there is pulmonary hypertension. So basically, it is the low pressure, low opening and low closing pressure valve and tends to get regurgitant quite easily if there is an increase in pulmonary artery pressures or for any reason the tricuspid annulus gets dilated, the valve gets regurgitant. That is one of the factors which makes it a very vulnerable valve. And also because of the low flow situation, it tends to get thrombosed easily, especially when a prosthesis is placed in the tricuspid position. The risk of valve thrombosis is much higher than the high flow valves compared to the aortic and the mitral valves. And also it involved many secondary diseases like carcinoid or infective endocarditis of the right heart, whereby it is an innocent bystander, but because it has to take the blood takes that path, especially take, for example, an intravenous drug abuser, where infections enter the bloodstream through the veins, the tricuspid valve takes the brunt of it and can develop tricuspid valve endocarditis. So that those are some peculiarities of the tricuspid valve: the exposure to low pressure, the complex subvalvular structure, and it easily becomes regurgitant. It's not resistant and it's not very competent at high pressures. Take, for example, just when tricuspid valve, there is a congenital corrected transposition or the congenital transposition has been corrected by surgery. If the tricuspid valve is exposed to lead to various problems, including right heart failure. So that is about the right atrium and some of the peculiarities. So here again, you see the anatomy of the tricuspid valve. It has an anterior leaflet, it has a septal leaflet and a posterior leaflet, as opposed to the mitral valve, which just has two leaflets, anterior and posterior. So here again, you see the top view of the valves, the tricuspid valve here. Like I said, it has a complex structure. The most anterior valve is, of course, the pulmonary valve, then the aortic valve, mitral, and tricuspid valves. This is the relative position of the valves in the human body. When you see it from above, you're seeing from the head side, this is how the valves will look like. So historically, it is thought to be a weak and non-essential valves. In fact, some of the congenital heart disease surgeries tended to exclude the tricuspid valve and make the right atrium a passive chamber, and thereby it is allowing passage of blood from the venous circulation into the lungs. That is what it was thought of as earlier, but we know that a competent tricuspid valve is very important for heart function, and especially in a patient with borderline heart functions or heart failure, it becomes extremely important to maintain competency of the tricuspid valve. It's the largest valve in the human body, having the largest annulus and the surface area. And as I mentioned earlier, it is a low flow area and therefore tends to thrombose quite easily. So what are the disorders that we commonly see of the tricuspid valve? They can be classified as congenital heart diseases whereby the valve is formed abnormally. There may be a congenital tricuspid stenosis or tricuspid atresia, where the valve may be totally absent. We all know that the valve and the ventricle are very closely connected, both embryologically and functionally, so that if there is no functioning valve, the ventricular chamber will not develop well. So a ventricular complex has to have a proper inflow in the form of a competent valve, a body, a proper outflow, and the outflow valve also has to be good. Then only the ventricular development and the ventricular function will be optimal. This is very important to understand because many of the congenital heart disorders are intertwined very closely. If the valve doesn't develop, the ventricle also doesn't develop. If the valve is stenosed, the ventricle tends to be small, sometimes with serious impairment of ventricular function. So the tricuspid valve also can be affected by rheumatic heart disease, though less commonly than with mitral valve disease. Mitral valve is the commonest affection, then the tricuspid, then the aortic, then the tricuspid, and then the pulmonary valve involvement. Degenerative disorders, just like in the mitral valve, can affect the tricuspid valve with calcification of the tricuspid leaflets and the annulus, making it regurgitant. Tricuspid valve, like I mentioned a short while ago, is more prone to infections from the venous bloodstream, infective endocarditis or any circulating uh, bacteria in the venous circulation can easily affect the tricuspid valve. It's also a victim of systemic disorders like carcinoid, or connective tissue disorders, or disorders causing pulmonary hypertension, where primarily the valve is an innocent bystander. There is pulmonary hypertension. Thereby, it gets regurgitant, and regurgitation leads to regurgitation and thereby causes worsening of both the anatomical problem as well as the functional problem to the patient. Of course, drugs and iatrogenic causes can affect the tricuspid valve, especially when you implant multiple pacemaker leads across the tricuspid valve. It tends to get regurgitant, though much of it is well tolerated. It may occasionally make the patient symptomatic. Any infection of the pacemaker leads or the ICD leads can give rise to tricuspid valve endocarditis. In any procedure which takes a device across the tricuspid valve, like balloon pulmonary valvuloplasty or a pulmonary valve implantation, these things can cause physical injury to the tricuspid valve, thereby leading to tricuspid regurgitation. So these are some of this is the spectrum of diseases that can affect the tricuspid valve. There may be prolapse, there may be stenosis. What are the anatomical types of tricuspid valve disease? There can be regurgitation, which is the most common problem in the tricuspid valve. A tricuspid prosthetic valve itself has various problems of its own, unique problems of its own, thrombosis, embolism. there can be congenitally an Epstein's anomaly, which is an anatomical malformation of the tricuspid valve. We'll try to see some of these conditions now. This is a normal tricuspid valve where you see the three leaflets as I described in the closed position. In tricuspid stenosis, you see that the orifice is narrow. So in a condition where it has to open fully, it is not fully open. So this is a picture of Epstein's anomaly, which I have chosen to just describe to you the anatomy. You have a large right atrium, which is much enlarged. There is a portion of the right ventricle which has become atrialized. That means it behaves like a atrial chamber because the septal leaflet has been shifted. The attachment of the septal leaflet to the interventricular septum has shifted apically. That means if the mitral valve is here, normally the tricuspid valve is a little lower, about 5 millimeter per meter square body surface area. But if it is more than that, if there's a gross shift, then it becomes a Epstein's anomaly or a Epstein's-like anomaly. The anterior leaflet of the tricuspid valve is large and sail-like. It's huge leaflet. The septal leaflet is small and apically displaced, thereby a large part of the ventricle becomes atrialized. It becomes functionally the atria. So the RV, functional RV is small. The function of this RV is impaired and thereby causing all the problems. It's also associated with the interatrial septal defect commonly. So this is one of the anatomical malformations, fairly common and familiar congenital heart disease. It has its own implications in terms of treatment. Just as an anatomical example, I showed you the Epstein's anomaly. So this is another condition where there is tricuspid atresia. That means there is no tricuspid valve at all. So like I said, if there is no tricuspid valve, the ventricle doesn't develop. The ventricle also becomes atretic. So you have a septum, a large ventricular septal defect. The left ventricle is pumping into both the aorta and the pulmonary artery. So the functional right ventricle will be very small in this condition. So in a condition like endomyocardial fibrosis, for example, it is secondarily, it involves the tricuspid valve. Though the leaflets are initially anatomically normal, the leaflets get involved by this endomyocardial fibrosis. You see in both the ventricles, there is endocardial thickening, calcification, and this disease process, there is thrombosis, extends onto the subvalvular apparatus equally on the left side and also on the right side. The right side is common in some of the populations. Regionally, it is more prominent, the right ventricular involvement, extension into the subvalvular tissue and thickening of the leaflets, calcification. This will lead to progressive disease, regurgitation. The valve function deteriorates, leading to various kinds of symptoms. So this is the another secondary affection of the tricuspid valve, whereby in a normal heart, normal sized right ventricle, the tricuspid valve is competent because the annulus is of normal size. In arrhythmogenic right ventricular cardiomyopathy, there is fatty replacement of the heart muscle. This gives rise to various types of arrhythmias. In extreme conditions, it may lead to cardiomyopathy, whereby the right ventricle is dilated. Functionally also, it might be affected. Basically, these patients died due to arrhythmias. So this is an example of tricuspid valve stenosis, where there is a narrowing of the valve. Normally, you can see the tricuspid valve orifice, unimpeded flow of blood from right atrium to right ventricle. Whereas when it is narrowed, if there is a narrow orifice, there is an elevation of the right atrial pressure, elevation on the of pressures on the venous side of the heart, and thereby various problems related to low cardiac output. So this is an example of tricuspid regurgitation, whereby the valve doesn't close properly. There's a lot of backflow into the right atrium with the consequence of elevation in the right atrial pressures. It is commonly seen due to pulmonary hypertension, but also there are causes which cause primary regurgitation of the tricuspid valve. But secondary tricuspid regurgitation is very common, especially due to pulmonary disease. Cor pulmonale is one condition where there is elevation in the pulmonary artery pressure. Consequently, pulmonary arterial pressure rises, then the right ventricular pressure rises, giving rise to tricuspid regurgitation. So what is the relationship of the tricuspid valve with other valvular diseases? We all know that the function of all the valves in the circulation is in a sequential manner, so that for a long time, over a period of several years, all the valves will ultimately get affected in one way or the other. They all have to function in a synchronized manner, and all the valves have to be competent and healthy. So mitral, aortic, and pulmonary disease significantly affect the tricuspid valve function. For example, in a mitral stenosis patient, pulmonary hypertension is a very common accompaniment leading to tricuspid regurgitation. In aortic valve disease, also in the advanced stages, tricuspid regurgitation, pulmonary hypertension becomes quite common. In pulmonary stenosis and pulmonary regurgitation, we very commonly see because the right ventricular chamber is directly affected. There are several complex interactions between primary and secondary factors. For example, in rheumatic heart disease, where mitral valve and tricuspid valve are affected by rheumatic process, but the secondary effects on the tricuspid valve, like mitral stenosis, pulmonary hypertension, secondary tricuspid regurgitation may be the dominant factor. It becomes extremely difficult to decide whether it is primary disease or secondary disease, though there are several echocardiographic criteria, pressure criteria, anatomical criteria. Many a time it becomes indistinguishable once the valve disease is established, and we have to treat based on several other factors. The pressure effect due to pulmonary hypertension, for example, when we are treating a mitral stenosis patient with a balloon mitral valvuloplasty or mitral valve replacement, what to do with the tricuspid valve? Should it be primarily replaced, or treat the mitral valve disease and wait for some time for the pulmonary arterial hypertension to come down and see how much it comes down? What is the fixed component? What is the variable component? All these are very difficult factors to assess. So what are the various symptoms that tricuspid valve disease can produce? It may mimic ischemic heart disease, congenital heart disease, rheumatic fever, hypertrophic or dilated cardiomyopathy. The common symptoms would be breathlessness, chest pain, palpitations, like in any other valvular heart disease. Fatigue, extreme degree of valvular disease causes, it can cause syncope, and peripheral edema is a very predominant feature in tricuspid valve disease. So on examination, the common findings are a raised JVP, cardiac murmurs, the right-sided heart murmurs, which characteristically increase with inspiration, which is a clinical examination point. The displaced apex beat, which is pushed laterally and outwards in the same space. Usually it is not displaced downwards because the right ventricle enlarges and pushes the left ventricular apex laterally in the same intercostal space. Leg crackles, hepatomegaly, hepatic pulsations, peripheral cyanosis, ascites. These are some of the features of tricuspid valve disease peculiar to tricuspid valve disease. So there are some easy methods. Now, of course, valvular heart disease, echo is the mainstay, and a good echocardiogram will give 90 to 95% of the diagnosis in valvular heart disease. It's really a boon that it can be done at the bedside. It is easily repeatable, and it's quite economical to do an echocardiogram as opposed to other invasive tests. So we should be able to interpret most of the valvular heart disease from echocardiographic data. Of course, ECG to see the rhythm. Chest radiograph will give us an idea of cardiomegaly and right atrial enlargement, especially. Cardiac catheterization, the role of cardiac catheterization has decreased of late because of the excellent developments in echocardiogram, transesophageal echo, and multiplane transesophageal echo, and various cardiac imaging techniques like cardiac MRI. In case the diagnosis is unresolved and you find a complex anomaly on echo, you can delineate it with a cardiac MRI rather than going for cardiac catheterization. Of course, cardiac catheterization is reserved for cases where you want some pressure data and oximetry data which cannot be obtained by non-invasive methods. In those cases, cardiac catheterization, especially congenital heart diseases where chamber pressures and chamber saturations are required, then we go for an invasive cardiac catheterization. So putting all these data together, we can come to a conclusion on several factors, whether tricuspid valve disease is primary or secondary, and what is the predominant type of affection of the tricuspid valve, and how do we go about treating this particular condition. So this is an example of ECG in Epstein's anomaly, where you see large P waves. In fact, they'll be much larger and bizarre, sometimes larger than the QRS complex itself, which is peculiar to Epstein's anomaly. So there are various stages of tricuspid regurgitation seen on echocardiography: progressive, asymptomatic, severe, and symptomatic severe. And what are the hemodynamic consequences and clinical symptoms? These can be seen from the chart. So here you see a tricuspid regurgitation jet. This is the right ventricle and right atrium. Here you see a very significant amount of regurgitation on color. So this is the RA, which is quite significantly enlarged in this particular patient. So from that, you can make out not only the anatomical quantity, the regurgitant orifice area, the regurgitant fraction, the volume of blood flow that is going back into the right atrium. You can also derive the pressures by using various types of equations. So once we have diagnosed, how do we treat this condition and what are the recent advances? There are some interesting recent advances, like I told you, in tricuspid valve disease treatment. In treatment, basically, there is medical management in most of the cases. As I mentioned before, it can be medically managed. When the patient is congested, you give them diuretics and reduce the congestion. That will make the patient symptomatically better. In conditions where the disease is in the other organ, like the lung, if there is pulmonary hypertension secondary to lung disease, you treat the lung disease to the maximum possible extent. There are excellent new agents to reduce the pulmonary artery pressure in type of in the form of PD inhibitors and various other drugs, which are now commonly used to reduce the pulmonary artery pressures, which will reduce the tricuspid regurgitation. We'll talk briefly about interventional management. So off late, we are seeing percutaneous therapies for all valves. Now, transcatheter aortic valve replacement has become standard of therapy and being used worldwide, and it has grown exponentially over the last few years. Now it has become a very normal practice to replace the aortic valve percutaneously, which has made things very simple. Patient gets a very rapid relief of symptoms and gets discharged very quickly, and recovery is also very fast. Only thing is the expense. So once that aortic valve was conquered, aortic valve was easily conquered because of the simple anatomy of three leaflet or bileaflet aortic valve. There is no much supporting structure which impedes the placement of a transcatheter valve. So it was pretty easy to design and develop, and over the years, nearly perfect valves have been developed from various parts of the world, and they have been being used in almost millions of patients, I would say, as of now. So once the aortic valve territory was conquered, people started looking at the same valve in a different form, in an inverted form in the mitral position, and then also in the tricuspid position. Of course, pulmonary valve implants antedated the aortic valve implant, so that we could have percutaneous therapies for all valves. So in fact, looking at the future, it would avoid surgery in most of the cases of valvular heart disease. Of course, surgery would have a role where for specific cases, but in most cases, we should be able to treat them with a percutaneous technique, thereby reducing the morbidity and mortality. So there are various devices which have come in for percutaneous angioplasty, including putting rings in the annulus. There is edge-to-edge repair, just like for the mitral valve, we do edge-to-edge repair by putting clips. There are tricuspid valve clips which can be used and placed and stitch the leaflets together totally percutaneously. There are replacements which are now available, total percutaneous replacement for the tricuspid valve. The first in human cases have been done with excellent results, and thereby alleviating the need for surgery in many of these patients are very, very morbid. In fact, many of the tricuspid valve patients who present have already had a open heart surgery for a mitral or aortic valve, especially the rheumatic variety, and right atrium, right ventricle are dilated. In many cases have right ventricular dysfunction, which makes them very high risk candidates for any open surgery. In those cases, if we select those patients suitably, they may benefit with good type of percutaneous treatments. So this is one example I would like to show you in tricuspid valve. You can see the tricuspid valve has been crossed and they are trying to place a valve there. So this is totally catheter based, and since it is a venous approach, a 24 French or a 28 French access will help us to do this procedure totally percutaneously. So this is a pledget based suture material which holds one of the leaflets, and then the same procedure is repeated on the other side. So when the knots are tightened, the leaflets tend to approximate better, thereby reducing the regurgitation significantly. Here they have shown, for pictorial representation purposes, they have shown complete disappearance of tricuspid regurgitation, but that doesn't happen in real time. When the annulus is shortened or the leaflets are stitched together percutaneously in edge-to-edge repair, there is a significant decrease in regurgitation by at least 1 to 2 grades, which will make the patient symptomatically much better in these morbid patients. This is another type of treatment called as the trick valve prosthesis, whereby two valves are placed, one in the superior vena cava and one in the inferior vena cava, thereby controlling blood flow into the right atrium so that the right ventricular preload is significantly reduced. You basically reduce or control the flow into the right atrium by putting these valves. In severe tricuspid regurgitation who are inoperable, they are not suitable for any surgery, end stage heart failure, they have liver dysfunction, they have heart failure. So in those patients, we can do this as a kind of a palliative procedure. And many patients have significant improvement in quality of life. The walking distance, the heart failure can improve. Right ventricle can remodel in the absence of severe pulmonary hypertension. The right ventricle can tend to remodel and thereby reduce the amount of tricuspid regurgitation. So this is again, this is the trick valve implant, the valve in the superior vena cava and another in the inferior vena cava. There is a valve here, there is a self-deploying valve here and a self-deploying valve here, whereby the valve regulates the flow into the right atrium. Consequently, the right ventricular inflow and the tricuspid regurgitation, everything reduces. So in summary, tricuspid valve disease carries a significant morbidity and mortality by itself, and also in combination when it becomes secondary disease, secondary to pulmonary hypertension or other valve disease or lung disease or a systemic disorder, so it bears the brunt of the disease and thereby causes symptoms and worsened outcomes for the patients. And as I showed in the last few slides, there are excellent new modalities for treatment of this otherwise hopeless patients. Nobody wants to reoperate on a patient with isolated tricuspid valve disease. They have already had an open heart surgery. They are very high risk for any future procedures. In those patients, there is an excellent a new ray of hope, I would say, for these patients to make their lives better. Thank you for the patient hearing, and I hope you had some good learning points in today's session. Thank you all for being here.
Thank you so much, sir, for your wonderful presentation. So we do have some question if you like to take that up.
Sure, definitely.
So the first question is, what are the special challenges and consideration in pediatric tricuspid valve disease management?
Absolutely. In pediatric tricuspid valve disease, most of the issues are congenital. So many of them would have surgical solutions like tricuspid stenosis or tricuspid atresia. Is a pretty common condition whereby there are multi-step procedures whereby blood is diverted from the venous circulation with a single ventricular repair where left ventricle acts as two ventricles and in fact pumps into both the circulations, and subsequently, if a true repair is possible, a two ventricular repair can be done. The size of the ventricles, the development of the ventricles, like I said in the initial part, the valve and the ventricle are totally interdependent. In that, if the valve is not at risk, valve is atretic or valve is stenosed, the ventricle has a developmental issues. So A patent, a competent valve is important for the development of the ventricle, both on the left side and the right side. So the size of the ventricle, the nature of the congenital heart disease, the complexity, the size of the child as such, these are the special challenges in the pediatric population as opposed to the adult population, where we can bring in several devices in the adult population. It's easier to treat.
Thank you, sir. The next question is: how has the role of 3D echocardiography evolved in the management of tricuspid valvular disease?
Beg your pardon. Can you repeat the question again?
Sure, sir. So the question is: how has the role of 3D echocardiography evolved in the management of tricuspid valvular disease?
CT echocardiography. CT scan or echocardiography. Okay, I'll take both the modalities. Both the modalities have had significant improvements as far as echocardiography is concerned. There are several developments in the form of 3D TE or even 4D, which is a reconstruction of the 3D multiplane transesophageal echo, which most of the lesions, almost 90 to 95% of valvular heart disease, can be delineated with echocardiography, transthoracic and transesophageal echocardiography. And in those cases where the anatomy is not clear, a CT heart or an MRI of the heart can delineate the rest of the conditions.
Thank you, sir. That's all from our audience, sir. So, sir, before concluding, sir, any last remark from you?
Yeah, I think I have summarized in the end of the talk, and thank you all for listening. And I hope it has been a great learning experience. We'll continue this series with more valve related talks, because valves are now, structural heart disease is a hot topic and several new developments are coming up, so that it's important for us to be aware of that, so that we can at least give the options to the patients. Even though the patients may not afford it, all patients may not afford it, we should be aware of the options that are available, so that we can help and make their lives better. Thank you all.
Thank you so much, sir, for joining us today. And with your permission,